is an e-mental health in practice project webinar. MPRAC is a project funded by the Australian federal government to acquaint general practitioners and all those working in mental health in primary care with the online resources, the reliable Australian online resources that are available for them to use in their practices. This is the 29th in the series of webinars presented by the Black Dog Institute, and tonight, as you all no doubt know, we're focusing on e-mental health and the prevention and treatment of perinatal mood disorders. Before we start, I'd like to acknowledge the traditional custodians of the land on which we meet and pay my and our respects to the elders past, present and emerging. The beautiful artwork on the screen is by my friend Bronwyn Bancroft from northern New South Wales. Here are some more QR codes that you might be interested in downloading the documents they're attached to. The first one is the references and resources list. There are a number of reference papers on that resource and all the addresses of all the programs that we're going to be talking about on the webinar tonight. And the one on the right, the QR code on the right, is in fact the handout form of the PowerPoint for the webinar. The learning objectives for the webinar, the formal learning objectives, are that we hope by the end of the webinar you as participants will be able to describe the prevalence, risk factors and impact of perinatal mood disorders, if you can't already. We'll hope you understand the use of screening tools and the diagnosis of patients at risk. We hope that you'll be able to identify referral pathways for your patients with perinatal mood disorders. I want you to be able to identify at least 3 online evidence-based resources that you can use to help support these patients. And last of all, and possibly the most important of all, I hope you might, by the end of the webinar, be able to describe ways in which you might incorporate these resources into your practice. I'm Jan Orman, GP Services Consultant at the Black Dog Institute. I'm a Sydney GP with a special interest in mental health, and I work as an educator in the professional education team here at Black Dog Institute. With me tonight, I have a stellar panel. I have Professor Jeanette Milgram, who is Director, Clinical and Health Psychology of the Parent Infant Research Institute at Austin Health, the University of Melbourne, and the lead in the Perinatal Depression E-Consortium. Did I get that right, Jeanette?
Mouthful, isn't it? Thanks, Jan.
It sure is. And it was the Perinatal Depression E-Consortium that contributed a large amount of the content of this webinar. Normally when you come to a Black Dog webinar, it's my content, but in this case, the E-Consortium has been very helpful in producing the content for the webinar. Also with us is Professor Jane Fisher.
Hello.
Jane, hi. Jane is the Finkel Professor of Global Health and Head of the Division of Social Sciences, Global Health and Women's Health, Public Health and Preventative Medicine at Monash University. I'm breathless.
Another mouthful, I'm sorry.
And those two are both psychologists by training. Jane tells me that she also works clinically, right, isn't it?
I do at an early parenting service here in Melbourne.
Yes, me too.
Yeah, you too, Jeanette? Okay, so we've got 2 academics with clinical strings to their bow, which is a fantastic combination. As well, we have Dr. Elizabeth Ma, who is a general practitioner and director of the Happy Babies Sleep and Settling Clinic in Melbourne. That sounds like a great place to be, Elizabeth.
It is. That's what I love to do.
Thank you so much for coming to the webinar, the 3 of you. It's great to have you here. The structure of the webinar tonight is that in the first part of the webinar, we're going to discuss the identification of risk for perinatal mood disorders and the identification of their presence. We're also in the second part of the webinar going to focus on evidence-based online resources. We'll have 2 case discussions at the end of the webinar. The first one's around transition to parenthood, and the second one will focus on depressive disorder itself. Dr. Alan Gemmell, who is the Research Director of the Parent Infant Research Institute, where Jeanette works. That's right, isn't it, Jeanette?
That's right,
okay.
Jan.
Now, I must warn you that the videos in this webinar are quite soft. And Alan has a wonderful Scottish accent, so you are going to have to listen to him very carefully.
Depression in pregnancy and the first year postpartum is a serious mental health condition with negative consequences for women's health and quality of life. Some of the biggest negative impacts are on the future developmental trajectory and mental health of children. Perinatal depression is highly prevalent. It can be treated successfully. However, more than 50% of cases continue to go unidentified, while less than half of these ever receive any treatment at all. Perhaps only 1 in 10 cases receiving adequate treatment. One way to improve on this situation is through the use of depression screening tests. Screening with an instrument like the EPDS has the potential to increase identification rates and therefore the number of women who can be offered effective treatment. Successful screening is a process, not just a test. Screening needs to be in the context of a coordinated, quality-assured system of care focused on supporting improved mental health outcomes for those women screened. Applying a screening test in isolation will have little impact on mental health outcomes. A number of factors are more frequently seen in women suffering from perinatal depression. These include a personal or family history of mental health difficulties, traumatic or stressful life events, and a lack of practical, financial, social or emotional support.
So what I want to ask you, stemming from that, is knowing that the Edinburgh Postnatal Depression Scale measures current mood state, are there any limitations to it? Jane, can I get you to answer that question?
I'm very pleased to. And I would endorse what Alan said about this being a very useful tool to use in care. But we do know that now, because it is widely available and it's a publicly available instrument, many women are familiar with it, and they're familiar with the scoring system, and they're familiar with what that means. And this means it can be open to intentional alterations, either to score it high if women are seeking access to services that are known to be difficult to get into, or perhaps artificially scoring it low when it's something they don't really wish to disclose. The other limitation is we know it doesn't always function so well in languages other than English. So for women for whom English is not their first language, we can't presume that it's as sensitive to their needs as it is for women who speak English as a first language.
Now, this question is a bit out of left field. Has it been validated for Indigenous women, Jane? Do you know?
There are a number of validations for Indigenous women, including some that use images rather than words. Mm-hmm. And I think they've been found to be a useful communication aid for Indigenous women, including women in remote communities.
Mm-hmm. Okay. Jeanette, did you have anything to add to that?
Yes, thank you, Jan. I think that Jane has pointed to some very useful limitations. I think, however, it is a very useful tool, and but it is a screening tool. So what we always have to remember is what that means. And the beauty of a screening tool is it quickly identifies in a very user-friendly way. Women quite like filling out the Edinburgh. Those women who are more likely to be depressed, and to be followed up for further assessment.
So, like any other self-report questionnaire, it needs to be used in conjunction with clinical assessment. And Elizabeth, when do you use it?
Well, I use it with every patient I see, actually, postnatally. I think it's very useful. As Jane and Jeanette have mentioned, there are limitations. I actually wanted to mention that often when I see patients who are doctors or psychologists, their scores are 0, which is not realistic at all, but something to be, aware of.
Mm-hmm. So it's about as reliable as the best self-report questionnaire, which is about 80% validity. The important thing to remember from my point of view is that it's a current state questionnaire. It doesn't tell you anything about risk generally, and that's where the antenatal risk questionnaire comes in, because it's got a whole lot of questions about history that measures risk. You can find the antenatal risk questionnaire at the website address that I've given you. If that's too quick for you, then I do believe it's on the resources list that you've got. Elizabeth, do you ever use the antenatal risk questionnaire? Where do you see it fitting into things?
It is very useful. It is different to the Edinburgh Postnatal Depression Scale. It's measuring the risk of developing a perinatal disorder. So it's a mental disorder. So it's a kind of more longer term. So you'd be more likely to do that once, and you'd be more likely to do the EPDS on a more regular basis.
Okay.
It's good to use alongside history takings. Again, it is a screening tool. So you do need to, if there is a high score of 23 or above, or if there's a significant history of mental health disorder, or if there's a history of abuse, it is very important to follow that up with a proper assessment.
So it might provide a good memory jogger for the sorts of questions that you need to ask in your clinical assessment. Yeah?
Yes, and there is a postnatal risk questionnaire as well, which has 3 added questions on the end.
How do we define perinatal depression? Jane, can I get you to answer this question? How do we define perinatal depression? Is what's written on the screen appropriate?
Well, look, it's an incredibly important thing that we now have so much more public awareness of the fact that women can experience mental health problems when they're pregnant or after they've given birth. And I think the recognition of perinatal or postnatal depression has been an enormous advance in women's health. But we do know that it can be an umbrella term, and there are definitely some women who are experiencing a pretty pure depressive disorder, and Jeanette is well positioned to address that in a minute. But I think we shouldn't lose sight of the fact that also many women can experience disability associated with pretty significant anxiety, or can have adjustment problems to these life events that take longer than other people do, and that do lead to problems of mild to moderate severity that warrant some assistance.
Here's the DSM description of major depression, clinical depression. Jeanette, does perinatal depression fit in here?
I think, as Jane says, that it's important to recognise that depression is a continuum and presents in, and it is useful for clinicians to be aware of the DSM criteria for depression, because it helps to define those women who are likely to have a major depression and need treatment, as opposed to perhaps support and only support, because those that need treatment also need support, or preventive measures. So I would say it's a very useful clinical tool to be aware of these criteria.
Jane, I've heard you talk about the things that make perinatal depression different from these DSM criteria. Can you say something about that?
Look, I think the 2 core DSM criteria, which are to do with significant weight change, especially weight loss, and with sleeping problems, are normal in women who've recently given birth. So it's normal for them to have experienced weight change, and it's normal for them to have interrupted sleep or insufficient sleep. So if these are 2 of the symptoms they endorse, then it's very important, I think, to inquire more closely into them, to learn a bit more about the nature of the sleep problems, in particular if they have difficulty going back to sleep after they've been up caring for a baby, but also if the weight change is really dramatically more than you would expect among a population who've recently given birth. And the last point there, is that when postnatal depression was first described, it was described as an atypical depression by Bryce Pitt, the psychiatrist who first identified it, because he said it was characterised by much more agitation and irritability than you can observe in depression at other phases of life. I think it is useful to hold this in mind, that if someone is irritable or agitated, it's really worth assessing whether they've got other depressive symptoms as well.
Mm-hmm. So it's like depression in other phases of life, but it's also not like depression in other phases
I
of
think
life.
that's the truth. It's got some unique hallmarks.
Okay, that's very straightforward. But there are some contentious issues around the definition in terms of onset, aren't there? You noticed in a previous slide it said within the first 4 weeks postnatally, but some definitions have it starting in the pregnancy and the possibility of onset being up to 12 months after birth. What are we to make of that?
Well, I think perhaps you pointed to what is the difference between the DSM criteria, which a lot of us submitted to when they were being prepared, that really was unrealistic, setting a 4-week limit. As clinicians, there's a general consensus, and in research studies, that postnatal depression is defined as in the first year postpartum. And when you look at epidemiological studies, you do see perhaps a hump around 3 months, maybe around 6 months. So that I do believe most clinicians ignore that 4-week marker.
It occurred to me this afternoon that 4-week marker probably applies to postnatal psychosis, does it not? That the greatest likelihood of developing postnatal psychosis as opposed to depression is in the 4 weeks postnatally. So we need not to be confused about that. And severity, is assessing severity of postnatal depression helpful in determining the management of it? Elizabeth?
I think it's, very important. It definitely directs our treatment approach. So if someone is diagnosed with a mild perinatal depression, we'd be more likely to use psychological strategies and maybe behavioural strategies for the infant, like a more structured or a structured approach or routine. Whereas for a more severe depression, we might be thinking about medication, possibly admission to a psychiatric mother-baby unit. And these mothers would require a lot more support, both professionally and socially, as well as a team approach.
I'm glad you mentioned social support, because that's certainly something that I think about in the perinatal period, that women and fathers need lots of social support, and some of them are lucky enough to have their mums.
Yes.
The other considerations in the perinatal period are largely sleep deprivation. That's a big deal to consider. Bereavement can occur in the perinatal period. The GPs amongst us need to think about thyroid dysfunction, anemia, and other medical conditions that can occur and masquerade as depression. And the allied mental health practitioners and psychologists amongst us need also to think about those things when women present with what appears to be depression and they haven't seen their GP for screening. And of course, we need to think about the medications they might be taking and the substance abuse that may be going on in terms of whether or not those things are producing symptoms that could be mistaken for depression in that perinatal period. Treatment. What's different about treatment of perinatal depressive disorders? Jane, can you comment on that?
Look, I'd be pleased to, but I think this is also an opportunity for Jeanette to talk to us about her unique expertise. But I think the first point that is made on the slide here is that postnatal depression is not just a matter of faulty biology. It might be attributed to that, but it occurs in a social context. So as we've heard already, that needs to be considered and taken into account. It occurs in a context when people are experiencing other difficult life experiences that might need to be addressed, but also it is one that is very amenable to helpful interventions, and I think Jeanette's mum mood booster is one of these.
Jeanette, I understand that cognitive behavioural therapy remains the gold standard treatment, psychological treatment in perinatal mood disorders. Is it different in any way from CBT for other disorders at other parts of the life cycle?
Yes, I think that it's very helpful to use a gold standard treatment like CBT that has proved itself helpful not just for depression but anxiety, which we hear is comorbid. But there do need to be adaptation. For example, you can't really have the time when you have a new baby to do relaxation for 20 minutes twice a day. So we've adapted our treatment programs to have relaxation on the run. There are all sorts of other symptoms of depression, as Jane has alluded to, that seem to be rather prominent in postnatal depression. So the difficulty in concentrating, so setting some very long cognitive exercises often isn't the first port of call. We'll very quickly try to get some change. We'll introduce some behavioural methods of activation. So you start doing pleasant activities with your babies and try to get immediately a boost by, as we know, that as you start experiencing more positive experiences, your mood lifts. So there are ways of doing this, and we need to take into account fathers and infants who are both very affected, as well as other partners, or if we have a single mum, well, you know, then there are significant others that are often involved in this. You'll see in your resources some information about how to keep the baby in mind, because this webinar is too short to deal with that relationship. That's a whole area of its own, but very important, and as is the relationship with other significant people in a woman's life.
So what I'm hearing you say is that CBT is ideal, but it does need to be modified a little bit to deal with the different circumstances that these women find themselves in, particularly their social circumstances. Let's take a look at those online resources that we've been promising to tell you about. And this particular one, Mum Mood Booster and Mum to Be Mood Booster, don't you love that logo, is a particularly close to Jeanette's heart, so I'm going to let her tell you about that, and she's going to tell me when she wants me to change the slides.
Thank you very much. So as you can see, we have developed, initially based on our very successful face-to-face treatments, which were adapted for new mums and pregnant mums, an online treatment, and one for postnatal depression and a similar version for pregnancy but adapted. And we developed these over 10 years, which was a long time, with some fantastic collaborators in the US. What I think is very unique about this online treatment is it's not a series of lessons or courses. It's as close as we could make it to face-to-face CBT, very interactive. And if you go to the next picture, we developed it at the Parent Infant Research Institute, you will see what the insides of the program look like. So at the bottom with the orange headings, there are 6 sessions which are very much a traditional CBT sessions, adapted to be very much simpler, more straightforward. You know, even cognitive challenging is just focusing on positive thinking. Women work their way through one a week, and they do that with or without the presence of a telephone coach. So we have a coached version where you can have a telephone coach. The clinician, if you're going to be a clinician using Mum Mood Booster, you can be the coach. And because we also have an SMS supported version where women get encouraging messages between the sessions to keep them motivated and engaged. Further up, you can see a series of library articles about communication, about managing your time and problem solving, so that women can freely do a lot between sessions. They can do some practice change homework activities. They can look at other things that might be relevant. And if they have a partner, there is also a partner website, which is totally separate, which is for partners of women with depression to understand what's going on, which can be very confusing. So that's a structure, and in the next slide, you'll see how right from the beginning we have tried to make it very interactive.
You've arrived at session 1, the first of the 6-session Mum Mood Booster program. We know that many mothers with new babies can have difficulty finding the time to use the web program, as well as making changes to your everyday routine. It can be hard to put yourself first, but by doing so, you will be in the best position to manage all the demands of motherhood. One last point before you get started. Please take your time, about a week, to work through each of the 6 sessions. There really isn't any benefit in going any faster. Your goal is to thoroughly explore each session. Thanks for listening, and welcome again to your Mum Mood Booster program.
program involves the way that your mood can become worse through a series of what feel like automatic reactions in a downward mood spiral. Typically, you start out experiencing a difficult situation. Then you have a negative thought that may be about yourself, the world, or your future, which makes you feel bad. You may feel depressed, anxious, frustrated, or any other unwanted feeling, which then affects what you say or do. This can make the original situation even worse, which makes you feel even worse.
So this downward spiral really captures how we very often feel if we're depressed and we just feel we're going down into the dark tunnel. And the program can then make it come alive by this image and then help women identify their own difficult situation thoughts. It's very individually tailored to whatever the issue whoever is doing the program is looking at. If you look at the next slide, without going more into the detail of what Mum Mood Booster does, it has a lot of other features. I just want to tell you a little bit about its very thorough evaluations in a number of RCTs, and it's been evaluated for women who actually have a major depressive disorder and also effective for those with a more minor disorder. What we found is which was quite astounding that it did so well, was that it was 4 times as effective as standard care. And we were talking about remission here, even for women who had severe symptoms. So we know that it works well. It works well in the trial situation, but also if you look at the next slide, it works well in the real world. So in the real world, where we've been having it out there, it also seems to reflect a similar pattern to that shown in controlled trials, which is really important because it's not always tested. You know, what works in a very highly controlled RCT may not translate into the real world. And the adherence is very good, particularly with a coached version or a clinician involved in monitoring the woman's use of it. And we know that you can use it as an adjunct in your practice. You can use it whilst you're doing other work.
Can I ask you a question about that coached version? How does that work? Is there actually a real live coach that works with the woman who's doing the program?
Yes, so the real life coach is a real person, and that's an option, and that works once a week. It's a short 20-minute engagement. Sometimes spends out a bit more, and it's not the therapy. It's supporting the woman because it's a program that does the therapy. We found the SMS version also is effective, but it allows some discussion. The coach can actually see with the mother's permission what she's been doing. There's a workbook that women can develop with their own strategies, with their own mood ratings and so on. And so the coach can go and say, hi, I see you've been really active this week and tell me a bit about what it's been like, and discuss more their use of the program, where they're stuck, what's been useful. And it's that human contact which I think has improved adherence, but it works both ways.
Mm-hmm. That's really good to know.
Yeah. So if we go to I think is the last one of this series, the benefits of the Mum Mood Booster program are that we do see a very rapid symptom reduction, and we find that there are many uses. I mean, we know there's a lot of women who can't really make it to the clinic, or there's a waiting time until you can see your practitioner, or the practitioner only has 10 psychology sessions and wants to be able to deal with a bereavement as well as monitoring what the woman is doing and being, in a sense, a coach online with her depressive. And it's also been shown to decrease anxiety symptoms. It's good for pregnant and new mums. And the high completion rate of any program we've seen, and as we said, coach or self-guided. But most importantly, at the bottom, we're very fortunate that as part of the Perinatal Depression Consortium initiative, We've been able to make it available free on MumSpace with the support of the Department of Health, the Australian Government. So,
do people have to go in via MumSpace for it to be free?
Yes.
Okay, so you go in via the MumSpace portal and then you can access it.
Then you can access it for free, yes.
Okay, excellent. Thank you very much for that.
And
so,
that's the MumSpace portal there.
That brings us to MumSpace. The MumSpace portal is put together by a consortium, that Perinatal Depression E-Consortium, is that right, Jeanette?
That's right. Yes.
Which consists of the organisations whose logos you can see along the bottom of the slide: Monash, QUT, Gene House, PANDA, and the Parent Infant Research Institute. So they have all contributed resources to the MumSpace hub.
You can find MumSpace easily on the internet, or you can go directly to our URL, mumspace.com.au. MumSpace incorporates not only our Mum Mood Booster program, but also other tools for when mothers need just a little extra help, and also tools for all new parents. We can think of this as stepping up from universal supports to intensive treatments. We will now take you through the other tools and resources available on.
So Mum Mood Booster is the treatment tool. Yep. But there are prevention tools within MumSpace, and that's what we're going to find out about now. This is Heidi Sturck from Queensland University of Technology. She wants to tell us about an app called Mind Mum.
Mind Mum is for the ups and downs that recent mothers are often going through. Every time you open it, Mind Mum gives a positive message at the top of the screen. You can track your mood simply in How I'm Feeling. And you can see your recent ratings in My Log. The app gives tips on understanding your feelings, helpful strategies, addressing issues, working on thoughts, connecting with others, and building well-being. In Feel Better, there are some great suggestions on things you can do to feel good. You can choose an enjoyable activity, who you'll do it with, and you can put it in your diary so you get a reminder. Calm has some resources to help you relax, and if you upload photos of good times with your baby, you can use those to feel good. In Work on It, you can solve a problem that has been making you distressed. Mind Mum isn't a treatment program, but it can be used alongside treatment or as a way to keep feeling good once treatment finishes.
Mind Mum's not going to suit everyone, but it is going to suit the people who are the app users. Another useful thing to know about in the preventative area comes from the Jean Hales Foundation, and Jane knows all about this. Jane, can you give us some sense of the structure of what were we thinking before we get Heather to tell us in a more formal way about it?
I'd be very pleased to. What we're thinking addresses directly two of the what are called modifiable risk factors for postnatal depression and anxiety. And these are the impact on a couple of their baby being unsettled, so dysregulated sleep, intense crying that's difficult to soothe, and the feeding problems that go with those. And also the difficulties most of us have when we have a baby in renegotiating who does what in ways that feel fair. So this program provides parents with very structured strategies to understand their baby's behaviour and how they can soothe and settle and regulate the baby and establish sustainable routines, and also how to negotiate with each other in ways that are more empathic and less characterised by conflict.
Can we see what Dr. Heather Rowe has to say about it before we talk a little bit more about the structure of the program? Is that okay with you, Jane?
Absolutely.
What Were We Thinking is designed for the prevention of postnatal mental health problems. Prevention requires that all members of the relevant population have access to the intervention, and therefore What Were We Thinking is embedded in the universal postnatal health system in child and family health services. It's innovative, including the father or non-birth parent and the baby in first-time parent groups and also in clinical practice. It addresses to risks that have been neglected in other attempts to prevent postnatal anxiety and depression, and it's positioned as meeting new parents' learning needs for skills about infant care and adjustments to their own relationship after this major life change. What Were We Thinking has high-level evidence of safety and effectiveness, and almost all parents agree that What Were We Thinking would be helpful to all new parents. Nurses too are appreciative of the additional tools, skills, concepts and language that they now have at their disposal in their work with parents. What Were We Thinking is designed in several formats which support delivery in a group setting or individually in clinical practice. It's available online too. All materials are easy to read and understanding is enhanced by the liberal use of engaging graphic images.
What I'm hearing in that is that What Were We Thinking is a face-to-face program, but it's been translated onto the online environment very effectively, both as a website and as an app. And that app has a 26-week following your baby through the progress kind of educational program, along with what's that about matching the expectations of the father and the mother, Jane? Did you say something about that before?
Yes, so on the website, a mother and a father can each fill in some responses to clear, simple questions, and then the app the online website has a way of combining them, which shows them how similar their observations of their baby are, or their experiences of the baby's birth, or their views about who should do what at home, and where there are points of difference. And then it provides some guidance for what they need to do to reach a more comparable understanding.
So kind of to get them both on the same page about what's going on. It sounds to me like the website and the app are complementary to each other and could be used together.
Absolutely. And I think they also do lend themselves to use within clinical practice, that a practitioner could introduce someone to these concepts if they can identify those things as being problems.
Mm-hmm. Okay. Let's have a look at Baby Steps, which comes from Queensland University of Technology. This is Professor David Kavanagh, who leads the team that developed Baby Steps.
Baby Steps is a web program for all new mums and dads. It helps them get prepared for the new baby and to deal with common challenges new parents face, with soothing the baby, feeding, improving the baby's sleeping habits, and ways of making the most of interactions with their baby. It also helps them with issues that arise in their relationships, the changing roles that occur when you have a new baby in the house, and ways to maximise self-care. Importantly, it has resources for fathers, both to give them tips on how to support their partner and on looking after their own well-being. Baby Steps is a way for all new parents to actually make the most of this exciting time with their baby, but it also provides some important psychological strategies for making sure that they are feeling okay.
So, Elizabeth, I'm hearing some crossover amongst these resources about their function. How do you make a decision as a clinician about which ones to recommend to particular people?
Well, I tend to recommend What Were We Thinking and Baby Steps for both parents. I find that it works quite well for both parents to get involved with both of these. The What Were We Thinking app, parents tend to like that if they like doing sort of getting small chunks of information at a time on a week-by-week basis, whereas the Baby Steps, it has more general information available. Patients can have a look at what they'd like to look at any particular time and click on that. The What Were We Thinking website, you can also do that, but it also has the more structured program as well. So,
Jane, with those weekly sessions in What Were We Thinking, can you not do them all at once? Can you not sit down and do 26 weeks at once?
It's a very good question. It's a flexible, searchable app. So if you decide you want to have all the sessions on infant crying at once rather than having them spaced out, you can search by topic, and that can then allow you to have a more concentrated amount of information. And you can easily go back. So if you want to revisit an earlier one, it's easy to do that.
I also, on the What Were We Thinking website, often refer to the videos there. They have great videos that are very practical for how to settle your baby, how to swaddle your baby, things like that, which you don't always get time for in a consult.
Mm-hmm, mm-hmm. So it sounds like there's a little bit of patient preference involved here too. So if they know about both programs or a number of programs, they can choose which style of delivery suits them the best.
Absolutely. And as a clinician, it really helps to have those apps already downloaded on your phone and be able to access the website during the consult, so you can show it to the patients at the time. It doesn't take a long time, and then they can decide for themselves which format they'd prefer.
Another thing I find very useful as a clinician is to get them to download it onto their smartphones themselves. So they've then got those URLs in their history on their smartphones, so they don't have to depend entirely on having seen it on your equipment.
Yeah, and it doesn't take very long.
So the ones that we've talked about are the ones that are available in mum space, but there are other tools to support your work with people with perinatal mood disorders as well. And they include the Towards Parenthood website, which helps reduce the risk in pregnancy, and we've got someone to tell us about it.
Towards Parenthood is an antenatal program for prospective parents. We believe that the antenatal period is a critical time to offer parents to be a realistic insight into what lies ahead so that they can be better prepared. It also provides information when people are receptive to learning. So as they're preparing for their baby, they're more interested in learning about what's lying ahead for them. It's a psychological intervention that we hope assists at this time of transition.
Another one that you need to know about is Momentum. You'll all be probably familiar with the This Way Up suite of courses and programs. Momentum comes from the This Way Up people. That's CRUFAD and St Vincent's Hospital in Sydney. You don't access it via Mumspace. You go straight to the This Way Up website. And I've got Siobhan Loughlin here to tell us a little bit about Momentum.
The Momentum programs are two brief 3-lesson internet-delivered courses based on cognitive behavioural therapy for anxiety and depression. One course is tailored for women during pregnancy and one for women in the postpartum period. Importantly, the Momentum programs are evidence-based. Both programs have been evaluated in gold standard randomised controlled trials in over 200 Australian women. The results from these studies have recently been published, and overall we found that both programs demonstrated significant reductions in anxiety and depressive symptoms after treatment. The programs also demonstrated high completion rates and positive patient feedback. So the Momentum programs differ from other online programs in a few ways. First, the Momentum programs are the only online treatment programs that explicitly target anxiety symptoms and comorbid anxiety and depression. It's important that perinatal anxiety is recognised and treated as distinct from depression, with women learning specific CBT skills to target these symptoms. The Momentum programs are also brief. Each program consists of 3 lessons and can be completed in as little as 4 to 6 weeks. The Momentum programs do not require clinician guidance or therapist coaching. Women have the choice to complete the program as self-guided or supervised, where they nominate a clinician to follow their progress throughout the course, such as their GP or psychologist. The Momentum courses are also paid courses. They cost $35 each, and this is simply because there is clear evidence that patients are more likely to complete online treatment if they've invested in the course just as they would with face-to-face treatment. Finally, who should you refer? The Momentum programs have been designed to be used as a first step standalone treatment intervention for all women experiencing mild to moderate symptoms of either anxiety or depression or psychological distress. Treatment can be started immediately with improvements in symptoms observed in as little as 4 to 6 weeks. This may be particularly attractive for women living in rural and regional Australia, where specialist clinician resources are often limited. The Momentum programs can also be implemented into your clinical practice as an enhancement to your valuable face-to-face session time. These programs are a useful way of accessing evidence-based skills training between appointments or for those women who are waiting to access face-to-face treatment. The Momentum programs are accessed through This Way Up Clinic. Once signed up, women complete a range of brief questionnaires before each lesson. We also have automatic email reminders and notifications that go to both the patient and the supervising clinician so that you can keep track of their progress throughout the course and be notified if more support is needed at any time. For more information, please visit thiswayup.org.au. You can also register here as a supervising clinician, preview the courses, and prescribe to your patients. You can also contact the This Way Up team with any questions regarding the programs, referrals, and our research. We also have flyers that we can provide you that you can give to women so that they can self-refer. And we also have clinician resources to help you integrate these digital services into your clinical practice.
Well, now we've provided you with a dilemma. We've introduced you to two different CBT programs, online programs for women with perinatal depression. That's Jeanette's program, which is Mum Mood Booster, and the This Way Up program, which is Momentum. And I'm getting confused with all these mums. I hope you're not. But the points of difference include the fact that Mum Mood Booster is free, but Momentum is a paid online course. But another point of difference is that Momentum connects directly with the referring practitioner, whereas Mum Mood Booster provides the support from the actual Mum Mood Booster clinic itself. Is that fair enough, Jeanette, those distinctions?
Yes, there are a number of other distinctions, of course. They're very different sorts of programs, from a course to more interactive, tailored face-to-face. So they're different sorts of programs.
Yes, different style. And I think whenever we're referring to e-mental health resources, we need to take that into consideration, that some people will respond better to one style than another.
Yeah.
PANDA is also something that we all need to know about if we're looking after people with perinatal anxiety and depression. This is Terry Smith from the PANDA organisation.
I want to share some information about PANDA and how we can support you to support your patients. First thing, I want to tell you about PANDA's national helpline. We've been operating the helpline now for 9 years, and we have around 15,000 conversations every year with women right across the country experiencing perinatal mental illness. What's important for you to know is that this is a really comprehensive service that's run by professional counsellors. The first call involves a full biopsychosocial and risk assessment, and so that we can really work out what's going on for that mum and work out the best way to help her. We take about an hour in that first call and then offer a follow-up service. We deal daily with mums experiencing anything from mild to acute mental illness and associated risk factors. To refer to PANDA's helpline, you have a couple of options. You can go to PANDA's website, look at the Health Professionals tab, and you'll find a referral form there, so for a formal referral. But alternatively, if you prefer, you can just let your patients know there's no need for a referral. They can just call PANDA directly. The helpline operates from Monday to Friday, 9 a.m. to 7:30 p.m.
So that's something that's really important for us all to know about, that there is a helpline that women can contact health professionals in order to get thorough assessment and direction to clinical help. Have you ever known any women that have used the PANDA helpline, Elizabeth?
Yes, well, I usually give out the number for any of my patients who are at risk of a mood disorder or have a diagnosed mood disorder, and it is an incredible resource. We're very lucky to have that available to us, so I highly recommend giving out the number to your patients.
It's a little like giving out the Lifeline number, isn't it?
It is, yeah.
So these are the things we've discussed. As you can see from the slide, the top half of the slide is available through the perinatal portal, that's MumSpace, and the other tools are available from other websites. Let's talk about some cases, though. We have not got much time. So, Jane, can you run us through Melita and Nick? The QR code in the bottom of the slide leads you to a written version of the case study if you're interested in acquiring it. But Jane's going to give us a potted version of Melita and Nick's story.
Melita and Nick are experiencing the kinds of problems that many of you would have seen in your clinical practice. That reproductive life hasn't quite unfolded as they'd anticipated. They didn't meet each other till their late 30s. Conception required assistance with IVF. And then at the end of the pregnancy, birth was by caesarean, which neither of them wanted. They have little family support because both of their parents are now quite aged and frail, and they're experiencing the financial worries of a single income. But the straw that's really influenced this couple is baby Sam's unpredictable, unsettled behaviour, prolonged crying, difficulty settling to sleep, and difficulty in keeping him asleep for longer than very short periods. So for this couple, their GP guided them through the What Were We Thinking approach, which helped them reduce the arguments they were having with each other and become much more skilled at recognising baby Sam's tired cues and using a more sustainable approach to settling him to sleep.
Elizabeth, might you have chosen something other than What Were We Thinking for Melita and Nick?
Well, I probably would have referred to What Were We Thinking, but another option would be Baby Steps that has quite general information about sleep and settling. If Melita and Nick were my patients, I would be focusing on providing them with an age-appropriate routine, wanting to stretch out the feeds a little bit, especially overnight, and focus on limiting awake times. And these things on their own can make a huge difference to unsettled babies, and a lot of that is outlined in the What Were We Thinking program. So as well as going through that in a consult, I would tell them to go away and have a look at the program as a backup to what we discuss in the consult. The Mind Mum app would also be useful in this situation. I think you could even get them to download it and do a work on it tool together during the consult just to get them started, so then they can continue doing that at home.
Mm-hmm. That's good to hear. Can I get you, Jeanette, to talk a little bit about Natasha and Tom, who are in a different situation altogether?
Sure. So Natasha is a young mum who has a 16-week-old baby. One of the resilience factors there is that she's got a supportive relationship with her husband, Tom, but she does have some of the risk factors in her history that we've talked about, past history of depression, family history of depression, and there's a particular stressor at the moment. Her mum had a recent breast cancer diagnosis. She finds it hard to ask for help. She's yearning to return to that pre-baby life, and we know that she's sad, tearful, can't sleep, loss of appetite and fatigue, and occasionally feels like it's all too much. So we're getting a feel, and if you can see the longer history that we provided for you, that it looks like that she has significant symptoms of depression. And so we would think that she is a good candidate for a Mum Mood Booster, with and without clinician support, depending on the clinical judgment. What Mum Mood Booster also provides is risk assessment. So we do that at entry, at 3 weeks and at 6 weeks. And if a woman is, if it's all too much, actually does suggest that there's some suicidal ideation, we quickly send risk alerts to the woman suggesting she goes back to her health professional. So there's those sorts of links back there. If, as a clinician, you'd like to know more what it's like for a mum to go into it, you can contact us and we can send you a tour of Mum Mood Booster. You can sort of see what your patient would be getting. But it's very much to hold and support her with and without the clinician help.
Elizabeth, what would you be doing with Natasha and Tom along with sending them to Mum Mood Booster?
Well, I would want to keep a close eye on them myself, so I'd be following up quite regularly with them, doing a risk assessment, a suicide risk assessment as well, and probably referring to a face-to-face psychologist or psychiatrist. But sometimes, these things do take time, so it is a really good opportunity for them to start on a CBT program immediately by using Mum Mood Booster in the meantime.
Okay, so you'd be holding them yourself and with Mum Mood Booster until they could get to the psychologist, with the expectation, Jeanette, that they might continue using Mum Mood Booster once they'd seen the psychologist?
Well, yes, they could, and because, in other words, they can be doing some work in between, some homework exercises that the clinician would be setting anyway, and the clinician can work with them in that way.
Mm-hmm. So I think that gives us all a good idea of how we, no matter what our professional background might be, using these particular tools. Thank you to my panellists for observing the chat box for me. I notice you've been doing a very good job of answering people's questions. I want to draw to your attention the modules, the learning modules on the impact page of the Black Dog Institute website, which are 6 accredited modules that help you learn more generally about e-mental health and how to use it with patients across the board, not just those in the perinatal period. We've got some really good feedback from people who've completed those modules, and those of you who haven't heard of them or haven't done them might find that they're actually an excellent way to find out how to integrate e-mental health into your practice. And I also want to repeat myself with the QR codes. If for those of you who missed them initially, these are the reference and resources code and the PowerPoint handout code, and the additional bonus resource that Jeanette mentioned, that is a secret resource that you'll find out what it is when you actually open it on your phone. I won't linger on that for too long, but if you have got the PowerPoint handout, I believe you also will have the QR codes. If not, send me an email. If you've got any complaints or any questions that are outstanding that didn't get answered, there's my email address. You can query and complain in my direction. That's jorman@blackdog.org.au. And there's a QR code on this slide too to allow you to fill out your post-webinar survey. I want to thank everybody for being here, all the 100 or more participants who've been here for the webinar. It's been fabulous to have you. I also want to thank Jeanette, Jane and Elizabeth for their contributions, their excellent contributions to this webinar. I'm sure all of us have learned a great deal. I certainly have learned a great deal about perinatal resources from you guys, and I hope that the participants in the webinar will be able to use them almost immediately when they return to work. I'll let them go home and have a bit of a sleep first, but then on their return to work tomorrow, perhaps they'll find somebody that can use these perinatal resources. So thanks everybody for being here, and thank you all out there in the audience. The most important thing off that slide to write down is my email address, just in case you missed anything. I'll expect to hear from you in the morning.